Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to part 2 of our sepsis discussion with Dr. Chris Horvat. If you missed our discussion about the new Phoenix sepsis criteria and pearls about evaluation, we highly suggest you go back and listen to that. But in the meantime, this episode, we're talking about treatment. Let's jump right back into it. So,
bundles.
Exactly.
Bundles.
We're going to kind of talk about this, Surviving Sepsis campaign and what we should be doing for each of these components when we see the patient. So, what medications off the bat should we be giving SEP? And of course, we can start with antibiotics.
Yeah, so early broad spectrum antibiotics are warranted for any patient that you're concerned about possible sepsis in. And those specific antibiotics, I mentioned cefepime and vancomycin earlier, based on the information that you presented, would probably be our go-to strategy for a patient like this. I can imagine institutions also using ceftriaxone and vancomycin. I can also imagine institutions using ceftriaxone monotherapy with a vancomycin escalation strategy. Although I would caveat that with, if there's any evidence that this is a MRSA pneumonia early on, that I'm a strong proponent of actually double covering MRSA, at least until you have a therapeutic vancomycin level, and preferably with a bactericidal agent. And so our practice locally would be, if we think that there's a history of MRSA or that nasal swab's positive, or we have those bilateral patchy infiltrates with maybe skin boils, then we're often going to start not just vancomycin in that scenario, but something like clindamycin or doxycycline to augment it as well for double coverage. And that's an extrapolation of Adrienne Randolph's work in her PIC-Flu collaborative, where there was, in an observational data set of children with influenza and MRSA, there was a 40% reduction in mortality associated with actually vancomycin plus another anti-MRSA agent compared to vancomycin alone. And you just don't see 40% mortality effects very often in medicine, especially in pediatrics. It's worth paying attention to. We, in terms of our sepsis guidelines locally here, and then in many places across the country, have organized different strata of empiric antibiotics based on categories of patients. So, for example, patients who are presenting with a neutropenic fever will get a certain set of antibiotics. Patients who have a history of chronic lung disease or cystic fibrosis have a different empiric regimen. Here in Pittsburgh, we have a really robust transplant population, and patients who have a short intestinal syndrome or received small bowel transplants in the past, and that also guides our approach, in particular looking at the antibiotic resistance patterns in individual patients and their historic cultures, and looking to see if there's a recent history of something like an extended spectrum beta-lactamase producing organism that may need something like a fluoroquinolone drug. And so thinking about all the possible things that could progress rapidly if you don't get them under control with appropriate antibiotics early is the way that we approach this.
Yes, you hit something that's 100% my favorite clinical pearl. We're not talking about routine tracheitis in this episode. We're talking about children who you are worried will die from infection. You're the resident, you're the med student. Get into the electronic medical record, search culture in the results section, and read all of those results. That's it. 3 years of PICU fellowship. I'm on the phone with the ED, always searching culture. You're going to find the ESBL producers, and you might actually change someone's outcome.
Yeah, and that's a great point, because those first 3 hours really, really matter. And the earlier you get that appropriate medication in, absolutely can make a dramatic difference.
Yeah, so that's actually my question. It's like, how quickly do I need to get the antibiotic in? So it sounds like 3 hours is reasonable, and not trying to see the patient right away and then throw it in by an hour or so. And
yeah, it's a
half hour.
It's a good question. It's a loaded question, and there's a lot of active discussion about what that appropriate threshold would be. And it's another example of something that's kind of impossible to concretely define for every individual patient, right? We can set these thresholds at the population level when we look at all the amalgamated data and look at what makes sense. But we know as physicians that patients are going to present at different points in their course, and some parents are going to wait longer to bring their child in. Some parents are going to bring their child in earlier. There's going to be different pathogens. Some of the gram-positive agents, gram-positive bacteria that can cause life-threatening infections might grow more insidiously in a patient. Some of the gram-negative ones will overwhelm the host rapidly. And the rule of thumb is that bacteria in appropriate media are going to double, every 15 to 20 minutes. And so common sense would then dictate the sooner you can get the antibiotic in that's going to kill those bacteria, the better. I mentioned the Ipso data earlier because that's some of the most robust data we have recently to suggest that 3-hour threshold is really important. Ronnie Lane did a secondary analysis of the Ipso data set recently and just published it in JAMA Network Open. And that was looking at children presenting to the emergency department with suspected sepsis. And in that case, 5 hours seemed to be the threshold. It looked like there was about a 5-hour window at the population level before mortality started to increase. With a really important caveat, and I think it's reflective of how practice has actually changed even in the last decade, which is that mortality was flat essentially between 30 minutes and 5 hours. But if you looked at less than 30 minutes, those children who got the antibiotics within 30 minutes of presenting, mortality was higher in those kids. And that, I think, is reflective of the fact that we as clinicians recognize the importance of timely antibiotics. And there's a lot of confounding by indication in those scenarios, meaning that we're giving antibiotics early for those kids we're really worried about who are presenting very sick and we're highly concerned about infection. We see the same thing locally when we track our time to antibiotic pretty closely across a variety of settings in our institution. And when we look at time to antibiotic in the PICU, the first dose, and looking amongst patients who are receiving their first antibiotic after 24 hours have already elapsed, so really looking at a collection of patients that are reflecting how quickly we're getting antibiotics in for new onset sepsis. The patients who receive it within an hour have higher mortality than those who receive it later. And again, I think it's confounding by indication in those scenarios. Once a certain level of illness severity is realized, then clinicians are acting pretty quickly. And that actually changes how we need to interpret these data as well. And so I recommend to trainees, I say, it's common sense. Like if you're worried about a bacterial infection, get the antibiotic in. That's going to do the job as quickly as possible. When you're thinking about how policies are constructed, that's a much more difficult question. Like in the adult world where they're starting to talk about reimbursement strategies around SEP1 recognition and management, they're being timed in the emergency department to get the antibiotics in, and it's reflected in the payments that they receive for patients. And it's based on population level data. And those population characteristics don't always translate to the individual patient that you're treating.
Chris, that's an incredible and nuanced approach. And, when they asked you the question, I thought you would kind of just give us the surviving sepsis, like that really, really effective diagram where it's like if shock's present, give antibiotics within an hour. And then, if you suspect sepsis, do your workup and get it within 3 hours. And I don't think you would say you would disagree with that, but you definitely bring the listener to understand, just how convoluted and complex this can be. And, that tension between wanting to do the best for the patient in front of you, but also you don't want to give antibiotics to every, child who has tachycardia. And that the tension is real. And I think we have to be open and have a nuanced approach with every patient in front of us. And that extends to how policies are made.
Yeah, I agree. I think there's you have to bear in mind the individualization that's necessary at the bedside as we think about the population level guidance. With additional, I think aspect worth noting being that the guidelines, especially as they've translated into these multi-center quality improvement initiatives, have really improved outcomes for children with sepsis. And so that idea of getting that fluid bolus in within the first hour, getting antibiotics in within at least 3 hours, ideally within the first hour as well, that is known to be associated with improved outcomes. And that's been shown in Ipso, it's been shown in single center data. The combination of blood culture, antibiotic, and fluid bolus in the New York State Registry data was associated with better outcomes as well. And so it's been shown repeatedly that early proactive approach is really influential in terms of generating positive outcomes. And so you're absolutely right. Like it's up to us to be stewards for a lot of these things. I think if you're thinking sepsis as a possibility, then it's often in that patient's interest that you treat sepsis accordingly.
And you were mentioning fluids. If it's all right for everybody, we're going to jump on to kind of just the next kind of component of this. So fluids, yes, we've kind of talked about fluids in lots of different ways. The big questions are, what fluid are we giving? How much fluids are we giving before we start talking about the next vasoactive pressure?
Yeah, that's a good one, and also an area of active study, as I think many are probably aware. The guidelines will recommend that we start with a 20 milliliter per kilogram bolus of isotonic crystalloid, and that we reassess with each bolus for signs of fluid overload, including crackles on auscultation, hepatomegaly, new signs of respiratory distress. And that's incredibly important and often an overlooked component of how we should approach fluid resuscitation. There's some, I think, exciting work being done in this area in terms of which fluid in particular we should be reaching for. Normal saline has long been the mainstay of medicine physicians and pediatricians as the resuscitation fluid of choice. Interestingly, the first IV fluids that were used for like the cholera epidemic, the 19th century, were probably more similar to the balance fluids that we use today, something like Hartmann's solution. And the surgeons we know often prefer their lactated ringers, and the anesthesiologists use their plasmolite in the OR. And there's increasing attention to those as potentially more beneficial compared to normal saline in terms of improving outcomes, and in particular things like the acquisition of acute kidney injury during sepsis resuscitation. Jury's out on that a little bit. I think if you look at the observational adult data in that space, it's, in my opinion, pretty compelling. There's really not a lot of reason, except for some specific edge cases, to not think about balanced fluids as the initial resuscitation strategy. We're hoping that the prompt bolus study, which has enrolled, I think, a few thousand children at this point, will help to answer that question. Really impressive, pragmatic trial being conducted with EFIC, emergency exception from informed consent, that is potentially going to be paradigm shifting in this space. We actually changed a long time ago. It was actually after a journal club I did when I was a fellow here in Pittsburgh. I was able to convince our ICU to start stocking plasmolite in all of the Pyxis machines. So I usually reach for plasmolite as my go-to fluid, with a couple of exceptions. One, if the patient's on a ketogenic diet, I don't like to use it because it has gluconate in it. And then if I have any concern about brain injury, I prefer normal saline. If you trace the history of normal saline in medicine, it's kind of like the trail kind of ends at some point in terms of how it was actually adopted. And it's probably related to some red blood cell fragility studies that were done early on that suggested that 154 milliequivalent per liter of sodium was what stabilized the red blood cell membrane most optimally. And so we started giving it and kind of ignored the fact that its pH is low and it makes patients acidotic. And for children with respiratory distress, it might drive the chloride up and make them breathe faster. Whether that actually impacts outcomes, maybe prompt bolus will help answer some of that.
Chris, if you signed a patient out to me that you were resuscitating just like a previously healthy 8-year-old with plasmolite, you would definitely get my attention. But I'm at a new hospital now. I've been asking for lactated ringers and nobody's looked at me weird. So, institutional differences.
There you go. And I have nothing against lactated ringers. I think it's a great fluid as well. I like plasmolite because it's 140 of sodium, and we love our sodium here in Pittsburgh with our neurocritical care population, and so we prefer a little bit higher rather than lower. But I think both are just fine. I think the other thing that people often will raise is a cost consideration. It's worth looking at your institution. I mean, last time I looked, it's been years, but the normal saline was less than $1 a bag, but the plasmolite was like $1.50 or $2 a bag in terms of cost to the pharmacy. It really was a pretty small difference in scope of care. And so, I encourage people to take those things into consideration as well as they decide about how to manage these scenarios.
Maybe
I don't know.
Maybe like long story short for the trainee, isotonic fluid is what you want to bolus, whether that's lactated
isotonic fluid with reassessment after each bolus, I would say, with bedside exams coupled with it.
Would you, after doing boluses, would you consider doing any maintenance afterwards, or is that a case-by-case basis?
Absolutely maintenance. And I think the things to keep in mind with maintenance, one would be that you really want to promote euglycemia. I've been observing sort of an effort of removing dextrose from a lot of fluids in patients in recent years. And I think some of that might be extrapolating for some of the adult data. Children, we've got wonderful classic literature to support the use of the D5 solutions that we use for maintenance fluids, and our 421 method, the Holiday Seeger approach for calculating maintenance rates, that I think are important to bear in mind. Now, one of the areas in sort of sepsis resuscitation that's gained a lot of attention is the potentially detrimental aspect of fluid overload in patients and the association between fluid overload and worse outcomes. It's an area of active investigation. It is something where there's certainly an association, but how much of that is confounding versus how much of that is that we're giving fluids in a really detrimental fashion, that I would say is unknown.
In terms of reassessment, is this where you might pull out focus again, maybe look at the IVC or look at heart contractility? Is that useful in these situations or not?
Yeah, it's a good question, and there actually there's a variety of methods you can look at fluid responsiveness in patients using. Again, POCUS is best proven, and this is based on the last time I looked at the literature, best proven really in patients who are intubated on neuromuscular blockade in terms of assessing their fluid responsiveness. Not to say that it's not useful, but incorporating it systematically into care can be a little bit more challenging in that regard. Looking at the heart, though, to see if there's qualitatively a deterioration in function as you've been administering fluid, that would be a really important step. Looking at the pleural spaces, especially over the course of a day or two, to see if they're accumulating fluid in a non-invasive fashion, that I think would be a great use for it as well. Other things that you can look at the bedside, just looking to see if the heart rate falls as you give a small bolus to patients. I do that all the time. In the ICU, the most common bolus I give is somewhere between 5 and 10 mLs per kilo because we commonly give them with a push-pull, and I'll stand there and I'll watch the effect on the blood pressure with an arterial line in place and the heart rate. And if the patient responds favorably to the first 5 mLs per kilo, I'll give another 5 mLs per kilo, just to the point where the patient seems to need it, and then we'll stop the fluid administration at that point. Passive leg raise can be a really nice way of assessing if a patient's going to be fluid responsive. So lifting the patient's legs up while they're laying flat to see if that induces a favorable decrease in the heart rate or improvement in blood pressure. That's a physiologically driven way to determine whether you should give some additional fluids. A little bit of gentle pressure on the liver as well, especially if continuous monitors in, to see if there's a favorable decrease in the heart rate or increase in blood pressure. Can also tell you if some additional preload might be beneficial in those circumstances. And so a number of different exam approaches that you can take to determine how to approach administering fluids. And not just it's not just that you can do those things, you should do those things in terms of how you're administering fluids. A common question from the trainees is, right, like, I just got called, they're tachycardic, should I give a fluid bolus? And I said, well, this is a nuanced decision. It is not something that is one size fits all.
Awesome. That was awesome.
And so, as we talk about fluids and we switch into the next medicine, which is pressors, at what point do we say this fluids is not going to do what we need it to do and we need to switch medicines?
Yeah. And so maybe we'll have a concrete answer to this one day as well at a population level, but it's another example of how individualizing therapies is so important. The guidelines will say really, once you start getting above 60 mLs per kilo of resuscitation, you need to start thinking about reaching for a vasoactive agent. And in pediatrics, that's now epinephrine or norepinephrine, depending on the circumstances. And we reach for norepinephrine when there's evidence that there is low systemic vascular resistance, and we reach for epinephrine when that systemic vascular resistance is high. So if the extremities are cold, epinephrine. If the extremities are warm, norepinephrine. And if the patient's profoundly tachycardic, norepinephrine. If the patient has a slightly elevated heart rate or normal heart rate in the face of low blood pressure, then epinephrine's a nice agent as a starting point to go with. We used to recommend dopamine. I think that's falling by the wayside. Epi and norepi are really the frontline therapies. Epi is still viewed maybe a little more favorably when it comes to giving something through a peripheral IV, although there's maybe some emerging literature to suggest that both are safe. And we will use norepinephrine in a pinch as well through a PIV, but we're often placing a central line in that case and using it as a bridge. If this patient has had recent steroids, we're often reaching for steroids pretty early in the course as well, but there's no resolution in terms of the timing or when exactly you should use steroids broadly in patients with sepsis. And so a lot of factors can influence that, but after about 60, somewhere between 60 and in practice even up to 100 per kilo in a patient like this who's not been eating or drinking for a couple of days and is also showing up with sepsis, they may have a substantial component of not just distributive shock related to their infection, but they may just be hypovolemic as well as part of their infection, and that can lead to needing more rather than less volume resuscitation.
Are there any other meds we should be thinking about outside of the common things, or are there maybe even meds that you have heard about down the pipeline that there's research being done on that we should be excited to come on? Should we be doing vitamin C in these patients with sepsis? I don't know.
Yeah, great question. I would say my practice is to not do vitamin C personally. We don't have a lot of data in pediatrics about this. There is some observational data that's been published that suggests maybe there's a benefit from the vitamin C thiamine hydrocortisone cocktail for patients with sepsis and multi-organ dysfunction. It's observational data. It's by no means perfect. There's one propensity score match study that had some, in my opinion, substantial limitations associated with it, and so has not been practice changing. We do have some emerging data from like the adult COVID space, for example, that vitamin C may actually be detrimental. That was the second ever multi-platform randomized control trials that I got to participate in. Lovett COVID and REMAP published that vitamin C was not beneficial for organ support free days in adults with COVID and probably detrimental. And so maybe some evidence there to suggest it's not entirely a benign therapy. There's exciting new antibiotics. I think that we're entering into an era now when we think about children who have life-threatening infection and organ dysfunction, multi-organ dysfunction and failure related to that. We are increasingly appreciating the genetic interplay and those individual biomolecular responses that are important, and only beginning to scratch the surface of how we might modulate those to improve some of the outcomes. Things like anakinra and GM-CSF, which are part of active trials now sponsored by the NICHD. We're hoping to get some answers on those in the near future. It's one of the ways that we tend to use ferritin to guide some of our decisions locally. If you have hyperferritinemic sepsis with multi-organ dysfunction, we're thinking about, should we be using anakinra in those patients? Should we be thinking maybe even of a monoclonal agent? But we need more data to really say those sorts of things conclusively and more broadly.
That's fascinating. And I think, as we get more information and we can personalize our approach to every, quote, septic shock in front of us, our patients are only stand to benefit from it. Chris, I wanted to add one medication for treating kids with sepsis. And it's so obvious you didn't mention it. It's corticosteroids. So if you have a patient with a suspected history or known history of adrenal insufficiency, it's likely their shock won't get reversed until you give them what they need, which is corticosteroids.
Yeah, you're exactly right. I think I probably switched gears before I completed a thought earlier when I was mentioning patients who had a recent history of steroid administration. I'm thinking about that early on. And it's a good example where the timing is also a little bit unclear. And your case is really apropos for it, because we've got a child here who's 8 years old with community-acquired pneumonia. And if we're to believe the adult Cape Cod study, well, there's another example of a potential 40% mortality benefit, albeit in adults, with initiation of a hydrocortisone infusion for moderate or severe community-acquired pneumonia in adult patients. And so, is there a comparable benefit that we could potentially see in pediatric patients by starting a hydrocortisone infusion earlier for community-acquired pneumonia? I think there's some compelling questions that need to be answered. We did have recently the Society of Critical Care release guidelines about corticosteroid use in critically ill pediatric and adult patients. And one of the conclusions there is we need more data. We need more high-quality studies about how to use steroids in these patients.
Oh, wow. Thank you so much for going through all this. This has been a wonderful discussion with you so far. We've gone through everything from our initial evaluation, how to diagnose, especially with our new sepsis criteria, treatment, management, all these things. I think our listeners will really enjoy this discussion, and we'll learn a lot, because I know I have. As we sort of get close to wrapping up, I think I'd like to ask ask if there's any other questions before I start getting to some wrap-up questions from any of our hosts.
Just to summarize a little bit, we had kind of asked you earlier, do you think this Phoenix criteria is going to change our management from either a diagnostic testing, right? Alice or Chris had both asked about, sending lactates versus coags versus some of those other pieces, or is it going to change any of those other components? What do you see us doing in the future? If it doesn't change our management now, what do you maybe see us doing in the future when we see this according to this, kind of Phoenix criteria?
And one of the ways that we're thinking about adopting it most immediately, actually locally, is as an outcome itself. Meaning that not living in an era where we've reduced sepsis mortality in the inpatient environment in the United States for children into like the 2.4% territory based on the IPSO numbers. And so we need surrogate outcomes that aren't mortality to understand how we're performing. And so it takes me back to that earlier example of that 14-year-old that you've been called to see in the ED whose heart rate's 180 and has urinalysis that suggests a urinary tract infection. And if you don't do things early, they're going to meet that patient's going to meet Phoenix criteria eventually. But if you do things right, hopefully you're going to alter the trajectory in a really favorable way, and that patient won't need a central line, that patient won't need vasoactives potentially. And so the Phoenix criteria may in themselves be a nice outcome, something that we can track and see how many of the patients who are presenting early with signs of a potentially life-threatening infection are actually progressing to meet the Phoenix criteria. So life-threatening infection with organ dysfunction as an intermediate step that we know is associated with higher mortality than that 2.4%. With respect to how it's going to guide clinical trial enrollment, I think it gives a nice set of structured guidance to identify a high-risk patient population for studying some of those more precision therapies. But I also think that there's going to be groups that are interrogating just exactly what that means for the specific therapies of interest. And one of the areas that we've heard a lot of chatter about already is, we overlooked creatinine potentially. And what does it mean when patients have acute kidney injury? Is that not a meaningful organ dysfunction? And the answer is that from a purely data-driven standpoint, while it didn't meaningfully influence the model in terms of its statistical performance characteristics. But there's probably still some things on the individual patient level, or especially when we're looking for precision therapies, that are highly relevant to take the creatinine into consideration for. And so I think there's going to be a lot more exciting work in this space to figure out exactly how to adapt these criteria to improve the care that we deliver.
Awesome.
So kind of the last piece I wanted to ask before send it back to Chris. So on this show, we're trying to highlight a lot of health disparities, any inequities, disparities associated with kind of each of our show topics. And we know that sepsis has a ton of research, and this has probably come up a lot. So I was hoping that you might be able to just expand a little bit on health inequities that we should pay attention to in regards to treatment for sepsis.
Yeah, one that comes to mind immediately that relates to sepsis, but really probably all the care that we deliver are going to be language barriers. We know that children and families who are seeking care for their children don't speak English have worse outcomes. They have more adverse events. In the adult literature, there's an association with mortality that's pretty strong. And for all the reasons that we've mentioned, that identifying and managing sepsis is a really nuanced thing in many cases. Determining sick or not sick is a really difficult thing to do. And a good history and strong ongoing communication play such a prominent role in that I think one of the things that comes to mind immediately when I approach a patient who doesn't speak English or whose family doesn't speak English is I think this is a high-risk scenario. And it's high risk that something bad might happen to this patient that shouldn't if they were speaking English otherwise. And that helps actually to heighten and elevate my approach to that circumstance and making sure I'm taking the appropriate caution to make sure that that I'm doing everything I can to mitigate that risk. The other inequity I should point to here that we're beginning to appreciate in more detail is going to be the vulnerability that comes along with medical complexity in patients. And that's really important many different diagnoses that we treat now in the inpatient setting. But for sepsis in particular, we know that children with medical complexity contend with sepsis more commonly than otherwise healthy children. We know that children with medical complexity acquire worse infections in the sense of, they're the ones who are more likely to get the multi-drug resistant organisms. And then we know that children with medical complexity are more likely to have sepsis readmissions as well. So be discharged and then come back with sepsis again. And we're fortunate in that we've been able to support many diseases into new territories of life, but it's generated something that I think we have to be mindful about facing as a challenge with unique needs, is that children who rely on technologies, children with chronic comorbidities, if we're not careful, there can be inequities in terms of how they receive care as well.
That was a great response. I just wanted to add one more thing. We've talked so much about how we deliver care to kids who have sepsis and septic shock in our high resource settings. We talk about maybe this 2% in hospital mortality, but when you look beyond the United States, you look to developing countries. A child perhaps with a Phoenix score of 6 might have a mortality risk of 2%, or maybe I'm not quoting the number correctly, modest. In these low resource settings, like, it's an overwhelmingly high chance of mortality. So the burden of mortality in sepsis is worldwide, and it's disproportionately felt in these countries that don't have access to resources like we have here.
Yeah, without question. And there is different pathogens to consider. There was a really compelling study recently where they administered azithromycin to children under 5 years of age, and I think it was West Africa, I'm not mistaken, and they saw a mortality benefit. And it was like, gosh, I can't remember the study in enough detail to quote it with too much accuracy, but it was once or twice a year they're giving azithromycin to children, and they saw a substantial reduction in mortality. And they actually saw a gradient response in that children who were further away from a medical center had more mortality benefit the further away that they were from a setting with more medical resources. And so there is no question a different set of challenges in the resource limited settings, and there's also a lot of opportunity, I think, to make a substantial difference for kids who suffer these life-threatening infections.
Awesome. Really appreciate you speaking on those issues and topics, as they're so important to everyone, and especially a lot of our listeners. So as we wrap up now, I want to ask, do you have any main take-home points you have for our listeners? We sort of crossed a lot today, and so I know it might be a little hard, but if you have 3 or 4 points that you want to make sure that our listeners, when they come out from this discussion, to make sure they remember.
Yeah, I think it was Erasmus who said that prevention is better than cure. And it comes to mind, certainly, with the Phoenix criteria. And what I want to emphasize actually are those 3 core domains that are so important for sepsis, which is, what is the patient's infection, what is their individual biomolecular response, and what are the systems of care that patient is part of for their recognition and management. And that is what improving, those are the 3 core domains that I think we have to be mindful about in order to continue to advance care for children with sepsis.
I would add, we are a bunch of, medical physicians here. If we had a surgeon on the call, we'd be remiss not to mention how important source control is. If you have a patient who's septic from a big abscess or big empyema, we got to drain the pus before they can get better. It can be really easy to get focused on titrating fluid, resuscitation, and vasoactives, but sometimes it's right in front of us what we need to do.
Totally agree. And I think in those 3 core domains, that falls in what is the patient's infection. And if it is an infection that will respond well to surgery, then they need surgery as soon as possible in those cases.
All right. So as we wrap up and we get close to signing off, is there anything you want to plug to our audience? Anything, any websites, any cool things that you just want them to know about before you sign off?
I think I want to highlight again both the Phoenix criteria, which were published this past February in JAMA, as well as the contribution of IPSO to the pediatric sepsis literature, because those things should be viewed together in terms of really marking a new era of pediatric sepsis recognition and treatment. We are seeing the best outcomes, thank goodness, that we've ever seen before related to pediatric sepsis. And it's going to be up to our generation now to figure out, how do we make things even better for the sickest patients who are meeting like the Phoenix criteria? And so I would encourage listeners, if they haven't familiarized themselves with those things and they're interested in sepsis, that please take a look at both the IPSO collaborative, which is now concluded but has several nice manuscripts from it, alongside the Phoenix criteria.
Excellent. Thank you again. I learned a whole bunch. I'm sure our listeners will. Hopefully we can have you back again at some point. Otherwise, I think they can catch you a little more over on the Peds Crit podcast as well. Is that right?
Yeah, the pleasure of being on that podcast as well. And that's right. And this has been absolutely great to be here. And thanks so much for having me.
Awesome. Thank you.
All right. This has been another episode of the Cribsiders.
It's for the kids.
For the kids.
And Peds Crit.
It's for the really
Kids. Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website, their website, at thecribsiders.com.
And also check out pedscrit.com or search for us on all podcasting apps to learn more pediatric critical care content.
So we're committed to providing you with high-value, practice-changing knowledge. To do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or contact us at thecribsiders@gmail.com. Special thanks to our Peds Crit team, Alex Shanklin and Zach Hodges, and our wonderful social media team on Twitter and Instagram. I've been Sam Mazer.
I've been Zach Hodges.
I've been Al Shanklin.
And this has been Chris the Chew Man Chew. Thank you. Good night. And a special bonus for those who have made it to the end. As always, a poem written by AI. This one's titled Silent Storm. In tiny veins a tempest brews, time ticks by, no moment to lose. Flushed cheeks and racing heart, the battle has only just to start. Vital signs, a telling tale, we must not let this young life fail. Fluids flow, a lifeline stream, to quench the fire that burns unseen. Cultures drawn, a search begins, for microscopic foes within. Antibiotics, our sword and shield, we pray the enemy will yield. Each hour counts, each action key to set this precious patient free. From sepsis grip, we'll break the chain and bring them back to health again. Vigilant eyes on every sign, adjusting course along the line. With knowledge, skill, and gentle care, we'll guide them through this dark nightmare. Though storm clouds gather, hope remains, for in our hands, life's spark sustains. Together we'll weather this silent storm and see our patient safe and warm. See you guys.